my pleasure to introduce our next guest honored speaker, Dr. Serena Hu. She joins us from Stanford University. She's professor and chief of the orthopedic spine surgery service. She did her training in Canada and her orthopedic residency at Hospital for Special Surgery, her fellowship at Rancho. She's current president of the AOA, first woman president of the American Orthopedic Association, and incoming president for SRS. So welcome, Dr. Hu. She'll speak on the evolution of pediatric deformity.
Thanks very much, Kyle, for the introduction. I am past president of the AOA, so I'm actually nobody right now, which is great. Thanks very much for asking me to speak and be part of this course. It's been great so far, and I know I'm looking forward to all the additional talks. You know you're getting old when they ask you to give the talk on history. But fortunately, it's before I've gotten old enough that I've forgotten it all, so somewhere in the in-between there. Anyway, so I'll be talking about idiopathic scoliosis, and it's really a historical overview, and mostly talking about innovations and the innovators. So I think a lot of us relate to hearing people's names and kind of famous people, and why are they attached to certain things that we describe these days. So these are my disclosures, and certainly relevant to that is the fact that I am an officer for the SRS and obviously have an interest in promoting that mission. The other ones aren't really relevant. So the early management of scoliosis was certainly something that we've all seen lots of pictures of, and Hippocrates first described longitudinal traction for treating these patients in 5 BC, and several centuries later Galen added direct lateral pressure to promote improving those curves. Paré from France described supportive braces in the 1500s, thinking that the deformity was from dislocation of the spine. The era of what you might think about perhaps modern or semi-modern treatment of scoliosis was probably in the 1800s when Sayre, who was the first professor of orthopedic surgery in the US, who was at Bellevue, believed that scoliosis was caused by muscular imbalance, so treatment should be gymnastic exercise. And one of his treatments was traction with a plaster cast to correct the spine deformity. And you can see in the illustrations on the bottom photographs of a patient who had the deformity with the right shift, as you see there, and she's put up in traction and a plaster cast applied with her proud doctors at the side there. Obviously, a big step forward in the treatment of scoliosis was when Röntgen in the late 1800s discovered X-rays, which allowed us to see better the actual internal anatomy going on with these patients. The treatment of TB of the spine certainly was I don't want to say a stepping stone, but part of our understanding and the need to treat these patients. And as TB of the spine became less common, actually poliomyelitis and post-polio scoliosis became more common. So there's sort of an overlap in as we treated the paralytic scoliosis compared to the idiopathic scoliosis. I want to give thanks to David Levine, who was one of my mentors at HSS, and he was a founding member of the SRS, and actually, believe it or not, made the suggestion for the SRS when he was a fellow. Can you imagine one of the fellows, who's a fellow here nowadays? Or a recent fellow? Can you imagine making a suggestion that would turn out to be the SRS? Do people listen to you that carefully? Think about something important, yeah. So he was the fourth chief of scoliosis surgery at HSS, and he's got a lot of interest in history, as some of us old fogies do, and he shared a lot of slides and data with me, so I'm appreciative to him for that. So the early treatment, as I mentioned, was physiotherapy-based, and the bottom position was considered the keynote position, which you can just imagine is the patient, kind of bending their spine to correct their spine. And that was considered important for treatment of the condition, as well as strengthening of the muscles, as you see on the right. I have a lot of patients nowadays who probably couldn't do that, let alone with a bun and a skirt like you see there. Forcible correction was the next step for these patients, and these I think we think of nowadays as being torture machines, but there were a lot of photographs that are found around in history books and in early articles talking about these plaster correction, traction tables, and really not until the Kleinberg brace here do you see something that resembles what we might currently do for a brace. This is the Abbott progressive padding, where they start with a rotated curved spine and sequentially add padding. And this is actually the results of a successful treatment with that Abbott brace where over the course of a year, they have essentially complete correction of that curvature of the spine. They did not show follow-up films, however, but so we don't know what happened to that child. Russell Hibbs was the first one to had described and published on a spinal fusion, and this was done for Pott's disease. He was a surgeon-in-chief at New York Orthopedic Dispensary and Hospital, which later became New York, orthopedic hospital affiliated with Columbia. And you can see from this diagram, he carefully peeled back the periosteum on both sides of the spine, took off the spinous processes, and then refabricated these and laid these down, and then closed the periosteum over that. So meticulous fusion technique was really, really a benchmark of getting a successful fusion. John Cobb, I think we all know his name. He was the first chief of scoliosis, the scoliosis service at what was called the Society for Ruptured and Crippled, and eventually became the Hospital for Special Surgery, because that brand's a lot better than a Hospital for Ruptured and Crippled. He used a turnbuckle cast and then for preoperative correction, and then cut a hole in that cast, that some of you may know, and then did a spinal fusion, and actually did this in a staged fashion because of use of progressive improvement and that turnbuckle cast, which you could correct over time. We all know the Cobb Angle, which clearly is the most useful thing you learned in geometry when you were in grade school. But nowadays computers do it, so you don't even have to understand the geometry. And of course, the Cobb elevator was sort of an innovation that we all depend on now. When I was a resident, I actually held a Cobb that actually had John Cobb's name on it, and I said, nah, this can't really be his. That was years before I got there. But talking to David Levine, apparently he used carbon steel Cobbs. And when he later, after I finished my residency, kind of went through the OR and kind of cleaned up stuff, there were actually Cobbs from John Cobb there. So I actually held a Cobb that John Cobb held, which is kind of cool if you think about it. And even many, many years ago, he was known for making the comment, you don't have to be crazy to do scoliosis, but it helps. So I think we all can relate to some of the challenges of treating scoliosis patients. This is a fusion treated at HSS, or the Ruptured and Crippled, and this is a 2-month post-op. And Albie actually had a different way of doing fusions. He put a tibial strut into the spine, and this is from the patient's own tibia, and provided some structural support. I'm seeing some nods there. Some people remember this. And he actually learned this technique from an uncle who was a tree farmer. So they grafted trees, and that's where he learned to go ahead and do this in the spine. And you can see that this is only 2 months post-op, but it looks like it's already incorporated in this child, and with nice correction there. The mainstay of treatment, as I've mentioned, is pre-op casting, post-op casting, and bed rest. And I actually couldn't find the book that a patient gave me, but she just wrote a whole book about the year that she spent in bed and how tortured she was lying in bed with these progressive casts. And so when patients complain to me about what I do to them now, I said, well, it could be like this. And they're like, oh, no, okay, this isn't that bad. So anyway, so in one of the first papers to come out about in the JBJS, because from the research committee, the AOA, was this study on the end result of the treatment of idiopathic scoliosis. And they had about 214 fusions, which occurred after failed conservative treatment. Most of them had a turnbuckle jacket. The average correction was 65%, which is actually pretty good if you just think about cast treatment, but lots of loss of correction by the end of treatment. About 60% had bone grafts. They described a 28% pseudoarthrosis rate, but if you look at the loss of correction, it's probably much higher than that. And most of these patients had about 3 months of recumbency as part of this treatment. And they had 2/3 of their patients that had fair to poor results, and only 1/3 that had good to excellent. So you can see why Cobb coined the phrase that you have to be kind of crazy, because treatment results were not very good in those days. The Risser localizer cast was another big step forward, where you would put these patients on traction tables and apply lateral and rotatory forces. He was a protege of Russell Hibbs, who you'll remember was the first to do that spine fusion. And of course, he was the first to describe the Risser sign, which is a sign of skeletal growth, and part of the history of learning that the growth phase of these kids was the most risky time for progression of curve. Walter Blount came along, and he was from Milwaukee, and originally designed the Milwaukee brace for post-polio treatment. And then this evolved to be non-operative options for an adolescent. You can see, many of you have seen pictures of this, but there's a pelvic piece that holds very firmly on the pelvis, and then these 3 metal upright pieces that can apply corrective forces to the rib humps and the lumbar prominences, as well as the chin and head piece that would apply a certain amount of axial traction. And it had very nice correction, but also could cause mandible deformities in patients at a very young age. So it was really, we forced people into this in those days, but you can see that it wasn't trivial to do so. John Moe is obviously a big name in the scoliosis world. He founded the first scoliosis service at Gillette Hospital in Minneapolis and was the founding president of the SRS. He wrote this book you see here, and this is the original version of it, and it's now on the 3rd edition, but I don't think there's a 4th edition because there's so many other competing books. He used a Risser localizer cast for his surgery and then a Milwaukee brace post-op. And he was presented basically that at a 15% pseudoarthrosis rate, which is quite remarkable compared to the earlier results there. He's credited by John Hall with convincing Harrington that a fusion was needed as part of a Harrington rod fusion, so that's really key from the standpoint of our current treatment of scoliosis. The Scoliosis Research Society, many of you have seen this picture of the founding members. David Levine is, who, as I mentioned, was a fellow when he kind of proposed the idea of a scoliosis club. And basically, this kind of coincided with John Moe starting to do yearly courses in orthopedic treatment that they did in Minneapolis. And it also coincided with the American Academy of Orthopedic Surgeons disbanding their scoliosis group because they couldn't get enough consensus among the group to have any forward movement. So it's kind of interesting that this group then gathered together and was able to have a uniform mission and whatnot. And as I mentioned, the bylaws were written by David Levine, and there are a number of other scoliosis prominent ones that you see here, and some of whom never went on to do more scoliosis surgery, but started that club. M&M is a big part of the Scoliosis Research Society meeting, as all of you who are members or candidate members know, and this is an early iteration of the card that was used to collect that data. And the M&M committee was chaired by Dean McEwen, and it was part of pulling of that data that helped them recognize that the neurologic complication rate was related to stretch during correction and recognition of the importance of the arteriovenous. They also recorded death within 1 year, and clearly we've advanced a lot in the way we collect morbidity and mortality, and we'll hopefully move on to a hand-based app in the next several years, which is something the SRS is working on. Dean McEwen was chief at DuPont, and I'm surprised it took till 1996 to have a patient like this, but he had a patient that refused that Milwaukee brace despite what was described as extensive counseling. And I can certainly attest to the fact that that's very difficult to convince a patient to wear. This is Dean McEwen with Eve Cottrell, who will become have more prominence later on in this talk. And he put the patients on a Risser frame and basically designed this cast with lateral corrections and straps, and then was able to fabricate a custom-made brace for those. And that really took over from the standpoint of what was used for management of idiopathic scoliosis conservatively for a number of years. This is a book given to me by Mark Asher when I was trying to put together some of the genealogy of the SRS, and Dogged Persistence really describes the work that Paul Harrington did to design his instrumentation. Currently, we have people who are on design teams or work with industry have teams, and Harrington did a lot of this by himself, and it was really that kind of persistence that got him to designing this, and I'll show you a couple of pictures in a section. So thanks also to Mark Asher, who passed away a few years ago. He was a Lifetime Achievement Award winner from both POSNA and SRS, which is pretty unusual. And he published Dogged Persistence because the Harrington papers reside at the University of Kansas, where Dr. Asher worked. And it was really a labor of love for the last years of his life. And it's really an incredible chronology of the history of scoliosis treatment up until that point in time, and excellent background background into Harrington's life and the history around him. So Paul Harrington presented shortly after the SRS was founded at the Academy on an instructional course on scoliosis and instrumentation. Prior instrumentation actually had not worked because the metal was not compatible, so it would actually dissolve the tissues around it and cause reaction and didn't work well. And Paul Harrington had also met with Mel Glimcher and talked about the structure and organization of bone, as well as visiting Enneking of tumor fame in Florida to discuss facet histology. Interestingly enough, he was very resistant to the idea of autograft bone, and he really thought calf bone was the way we should be going. And he even set up processing to try to minimize the reactivity of a human body to calf bone. And he also looked into other metallic testing. So the book, if you ever have a chance to read it, is filled with these beautiful drawings from Paul Harrington. And he, as I mentioned, did not have engineers for the most part. He had one engineer that he worked with, but he basically did most of the actual designs here. And this is the original picture of his Harrington rod with a ratchet here and a hook that you can insert under the lamina, as you can see there. And they talk about all the different aspects and the measurements, rod sizes, things like that. He had a self-addressing spine strut that it would adjust during instrumentation. And you can see that the hook is now a little bit more well-designed and more kind of precise from an engineering standpoint. This is a picture from his book, from the book on how the Harrington fusion actually works. And so most of us don't realize that the original Harrington instrumentation was designed to have an outrigger to actually apply correction. Then you'd put in the compression hooks on the convexity of the rod, and then remove the outrigger, and then apply your distraction rod. And as I mentioned, this is with a fusion, but at first Harrington did not do a fusion at all, let alone with the bovine bone or human bone. I thought this was kind of interesting point to bring up. So royalties were fixed payment. So it's amazing. The distraction, compression, 8-rod hook construct that would typically be inserted for a thoracic curve was $59 in those days. And I have to say I didn't do the calculation to convert it to current dollars. And royalty to Harrington was $5 or 3%. But this didn't change if you raised the price or if inflation happened. So Zimmer had the exclusive rights. Harrington did not have a patent because in those days it was thought this was something for the good of the general population, and it was actually partially funded by the same people who funded the Salk polio vaccine design, and so it wasn't felt that Harrington had rights to those patents. It thought it was like for the greater good of humanity. Nevertheless, he did get $3,700 of royalties in 1962, but again, as the prices went up, Harrington's cut did not go up, and as he suffered he was a pretty bad vasculopath, and as he got more ill, he actually had to rely on some of these royalties for his living expenses because he didn't have a big pot of money at the end. I just wanted to point out here that Harrington actually had a pedicle screw instrumentation system even then that he thought would be used for spondylolisthesis reduction. Obviously this wasn't feasible because it would put the patients in more distraction, but that he understood the basic idea even that long ago. And so pedicle screws long before we use them more commonly. So I mentioned David Levine. He did the first Harrington rod at HSS, and he was a big proponent of the team approach. So this picture shows the chief of pediatrics helping him with this patient in cateteral traction. There's also other pictures of him with the chief of anesthesia and the chief of pulmonology, recognizing how important the rest of the team was to patient care. This is that first patient in 1967. That's what her curve looked like. This is her 6 months post-op. She managed to have twins at the age of 42. And this is her in 2007. She actually volunteered at HSS up until fairly recently and never needed more surgery. So she did very well, and is a kind of a nice story regarding that. So a lot of people concentrated on the posterior spine instrumentation for obvious reasons. That's what spine surgeons are more familiar with. But Alan Dwyer from Australia visited Arthur Hodgkin in Hong Kong, which, as many of you know, is a place that had to deal with a lot of Pott's disease. And Dwyer got the idea of excising wedges from the anterior spine to help correct scoliosis in those patients. So this is the Dwyer device where you have screws and washers placed into the body, and then this cable that you see here that you would thread through and apply corrective forces to correct the curve. Unfortunately, he didn't live very long because he had cancer of the esophagus. But he passed on the mantle and encouraged Klaus Zilke from Germany to improve that technique. So again, Dwyer's technique, of course, created kyphosis, and since it was oftentimes used in the lumbar spine, it was recognized as not being good for a patient's overall balance. Also because the cable needed to be crimped, it couldn't be adjusted over time. So Zilke designed an anterior threaded rod that had nuts that you could tighten over time, and there was a derotation device that you would connect to the two ends of the construct, so it was a vertebral derotation system, and he presented on some very nice results in 46 cases. And then later, John Hall and Lyle McHaley from Boston Children's presented the Dwyer's type system with a solid titanium rod again to try to avoid kyphosis in that area. So this evolved to more rigid instrumentation where an inner body support could be applied to avoid kyphosis in the lumbar spine, and it was applied quite widely and basically kind of the procedure of choice for single, relatively flexible curves, particularly in the thoracolumbar and lumbar spine. So John Hall is certainly a lion of the scoliosis world, and he was president of the SRS in 1969. And at his meeting, they focused on pulmonary function, which was starting to be recognized as being a considerable risk for some of the severely involved patients. And they realized that arm span was a better predictor of what the pulmonary function should be, since the patient's trunks were shortened because of the scoliosis. And so arm span was a better predictor of their pulmonary function deficit than using their height, and found that curves over 60 could potentially be affected. He reported on 32 patients with Dwyer instrumentation at that meeting. This is not his case, but John Hall was known for doing a short segment overcorrection to try to minimize the amount of fusion the patient needed, and the patients did quite well from that, and he also got a Lifetime Achievement Award and was certainly highly important in the world of adolescent scoliosis and pediatric scoliosis. To avoid being too North American-centric, Pierre Stagnara had actually been an early treater of complex adult deformity, and this led him to need to design something to keep his patients more safe neurologically. So he's the one who some of you don't know that the wake-up test is really the Stagnara wake-up test. And so you'd obviously lighten up the anesthesia, wake up the patients, and have them move their feet, and he presented on this in 1972. And really kind of changed the way that we approached scoliosis treatment. He also had previously been recognized as a organized non-surgical approach for casts and braces, which he called the Lyonnaise School, which sounds more like a cooking school to me, but nevertheless, a lot of French things sound more food-related. And he also recognized the rotational nature of scoliosis. So some of you may know that there's a Stagnara view of the spine, which is an X-ray of the AP of the spine, not an AP of the patient. So the patient is very rotated. You will underestimate the amount of their curve measurement, their Cobb measurement, because the rotation is not taken into account. So that was one of his contributions as well. And this is a picture from one of John Dubasset's articles showing Pierre Stagnara at work. So Les Nash took the neurologic issue to the next step, which is publishing on spinal cord monitoring. And he used a cat model and actually was able to recognize the role of blood pressure in spinal cord monitoring. And this is obviously critical to what our current understanding and treatment is for those kind of intraoperative issues. In 1975, with Winter, Simmons, and Dixon, they established the Harrington Guest Lectureship at the SRS. I was fortunate enough to know Les Nash pretty well, not only because he was the father-in-law of one of my fellow residents, but also because we traveled with him as a senior traveling fellow throughout Europe. This is Kirk Wood, one of my fellows, Yossi Margulis, and Randy Puno, and there's Les Nash. I think this is in Italy someplace, given the jovial nature of this group. Luque was certainly a well-known change in the way we treat scoliosis. He's Spanish and Mexican, and I actually didn't realize that he was a Stanford undergrad and also went to medical school there, and then had his internship at McGill. So this is kind of, I've spoken to Luque numerous times over the years, but never realized how much we had in common. He did his residency at LA Orthopedic Hospital with Joe Risser. and later married Risser's daughter, interestingly enough. So that's one of the kind of folklore of the world of spine surgery. He obviously was known for the Lukey wires and segmental spinal instrumentation, and interestingly enough, he actually picked this up from a neurosurgeon colleagues who used it for cervical spine trauma, and realized that sublaminar wires could be used for multiplane correction and allowed no postoperative immobilization, which was particularly useful in the Mexican very hot environment where you can imagine casting would be fairly miserable. Another advancement in the treatment of scoliosis was certainly the King-Mo classification and trying to decide when a selective thoracic fusion would be appropriate. And so they looked at their 29-year experience from the Twin Cities Scoliosis Center and found that lumbar fusion was only needed in about 13 to 14% of those patients. And that was really important from the standpoint of saving fusion levels in these people. And this article also popularized the previously recognized stable zone of Harrington, where you want to have the patients centered in that area there. CD instrumentation, how many people have used CD instrumentation in this audience? A diminishingly small number of people. So you saw Yves Cottrell in an earlier picture with Dean McEwen, and this is Jean Dubasset, and obviously they're French, and they brought the CD instrumentation, the variable hook rod construct, to the US in 1984, which is when I started my residency, and some of these people weren't alive at this point in time. And it allowed derotation, distraction, compression, and translation. So really the first attempt to do three-dimensional correction from a posterior approach. So you can apply distraction in the concavity of the curve, compression in the convexity of the curve. You can do this appropriately, so compression in the lumbar spine, so you wouldn't be flattening out the spine, and compression in the thoracic spine, so you would not be causing more kyphosis. It was rigid and stable enough to eliminate bed rest in the cast, so even though it cost $3,000 compared to, look at how much the price of Harrington rods have gone up, it was thought to be worth it because you'd get so much better correction and also eliminate the need for bed rest for these patients. With further improved instrumentation, it was obviously necessary to have a classification system that took that into account. And so the Harm Study Group looked at their data and published what is now known as the Lenke classification. And they classified the three types of curves in a typical idiopathic scoliosis as to whether they were non-structural or structural based on the flexibility and the magnitude. They were the first to put in the sagittal profile as far as understanding whether or not, how that contributed to the surgical planning, as well as the deviation of the lumbar curve from the midline. And so this is pretty much the standard of how we classify curves nowadays in idiopathic scoliosis, and has really helped from the standpoint of learning when you can stop short and or need to include a curve. Nevertheless, this study actually took the people from the Harm Study Group who actually rated did the classification, and you can see that even though the classification system was out there since 2001, the types of Lenke curves that have lower frequency still get classified in the wrong way in a significant number of patients. So it's out there, but we're actually not as good at applying it as we should be, and sometimes with significant consequence. Obviously, we don't do a lot of wake-up tests these days, so in the late 1980s and early 1990s, motor-evoked potential started becoming available and prominent and safe. It's certainly more accurate than SSEPs, does require a change in anesthesia, and nowadays wake-up tests are certainly less frequently and rarely needed. Who here has done a wake-up test in the last 6 months? Yeah. Was that a failure of motor MMEPs or something? Yeah. So it's a good backup option, and I think it's something.
Usually it comes back while you're going towards the wake-up test.
Yes, I've definitely seen that, but it's good to remember because the problem is that most anesthesiologists nowadays don't know how to do it. They're like, oh my God, I've never done a wake-up test, but they need to know because there are. I think that was the last 6 months, but I think in our lifetimes, how many people have done a wake-up test? Yeah. You need to know how to do it and remember to make sure your anesthesiologist knows what to, they kind of know what to do, but it's helpful if they're prepared. And you don't need it often, but the one time I forget to tell my patient that it might happen, or that my anesthesiologist that it might happen, will probably be the time that I lose my motors and need to do it. So certainly, this is something that has really changed the safety from the standpoint of doing many of our spine surgeries. Sook in the 1990s was able to show us how to do thoracic pedicle screws. So a lot of us remember SRS meetings where he would show these x-rays and we'd look at them and peer at these K-wires all over the place and say, where are they? But they were in the pedicles, and very accurately so. And he presented in 1995 comparison of patients who had the hook configuration, screws that were placed in the hook configuration, and then high-density segmental screws at each level, within a markedly improved difference in the amount of correction you'd achieve with segmental screws at every level. Also improved compensatory curve correction and the ability to get rotational correction as well. And so again, this is probably one of the latest innovations that has moved to standard of care in our treatment of both adolescent and adult scoliosis patients. The last talk talked a lot about, where is he? How patients don't like to get a fusion. And so towards that, I think there have been a lot of doctors thinking about how to avoid fusion in our patients. And so John Braun, who actually used to be he was at HSS before and then did a Minnesota fellowship, and he and Jim Ogilvie looked at a goat model, and they created a scoliosis with a posterior tether, and then applied a nitinol staple, which would compress across that the disc and the growth plates on that convexity, and then over time the curve could, the concavity could grow. This is a common technique in orthopedic surgery when we do epiphyseodesis around angular deformities, and it works quite well, and you can see here it works quite well in animals as well as in human patients. And so this is also around the same time. Peter Newton had, and Stéphane Perron had similar experience creating scoliosis. This is an example of a tether, which is kind of the next iteration where screws are placed into the vertebral bodies, and then I think it's a polyethylene tether, but it's a cord that's applied and compression applied. And in their early results at 2 years, this is one of course, you always show your best cases in the article. And so this kid went from a 42-degree curve pre-op, 23 post-op, and then to 10 degrees after treatment and 2 years of growth. But notably, of their 11 patients, 2 of them were overcorrected in the wrong direction. So it's a very powerful technique, and they had to adjust and loosen the tether. Notably, it does not correct the rib deformity, and you can't do it with thoracic, or you shouldn't do it with thoracic kyphosis because it'll aggravate your kyphosis. So it's certainly something that is being used more commonly nowadays. There's also a dynamic system which was designed by Floman from Israel, and you can see that with movement of the patient, it kind of ratchets out and distracts a little bit more, but you can also see that there's kind of a change in angulation proximally. So although the results have been good in Floman's hands, and I think a few of these co-authors as well, the results may not be as good in the non-designer's hands. So I think that the patients certainly want to avoid the F word of fusion. And so regardless of whether or not we know what the indications are, we try to please patients. There's some that just want to market to get those patients, and non-fusion is certainly desired whenever possible. But indications will definitely be stretched or even flouted in some cases. And the problem is this will result in failures, and there'll probably be an uptick in failures as people try to stretch and push the indications. Before we go to fusionless surgery, we need to understand better the material properties, because most of these things will break over time. You know, nothing that's not alive will not fatigue over time. And we need to understand spine motion over time and a better understanding of what happens with the aging spine. So I don't know if fusionless surgery is going to be in the future in my lifetime, but hopefully eventually we'll get to that for our patients. But I do think that precision medicine will certainly help us with that. Some of us know about the Scully Score, where that came out, where the idea was that the kids with scoliosis could send a spit which would have some scrapings from their mouth and would be genetically tested. And low-risk people would be told, oh, you don't have to wear a brace at all. High-risk people would be told, oh, you really, really, really better wear a brace because your scoliosis is probably going to get worse. The problem was the majority of patients fell in this gray area. The other problem is the Scully Score was designed on Caucasian teens in Utah, which was a highly homogeneous group but had great genetics because everybody has a family tree, but they really couldn't reproduce this in other populations. So there are certainly multiple candidate genes being considered from the standpoint of better understanding the genetics, but currently we are not there to have a Scully Score that's universally applicable. But certainly early diagnosis and potentially genetic or molecular diagnosis may be what we need to do in the future. Chris may be able to apply his techniques to the pediatric patients, and hopefully in the future we'll continue to improve the way we treat these patients. So thank you very much for allowing me to take this trip down memory lane, and I don't know if anybody has questions. So.
Well, Serena, not to let you go without a question. that was a terrific overview, really, really spectacular. And if you were to look over time, and your perspective is so valuable, what do you think's been the single biggest change that you've seen in your career, be it instrumentation or biologics or diagnostic techniques or minimally invasive surgery? What do you think is the most impactful change that you've seen?
It's probably a combination of improved instrumentation. This is the waffling answer because there's a lot. So there's improved instrumentation, which allows us to correct more. The problem is that actually about a month ago I did a talk on what happens when you don't follow the rules for the Linke classification, and it was interesting. When you don't follow the rules, you try to get away with things, and the thing that actually happened the most that led to the problems was not just not following the rules, but overcorrecting. So if you correct beyond if you try to save levels and overcorrect your primary curve, then you end up with the other curve not being able to compensate or trying to, so we have such powerful tools nowadays that I think that it's beyond what the rules were designed to do. So, okay, a fusion, the less you fuse, the better. But if you're going to end up with, I had these unbelievable cases of what happens when you overcorrect and then fuse too short. And it was like, you're better off just getting the curve right. If the person has a fusion to, some of the decisions were between like T12 and T11. I'm like, does that really make a difference for the kid? Why would you even bother to try to save that level, aside from the fact that you could tell them they had a shorter fusion? So I think we're kind of getting too far ahead of ourselves from the standpoint of recognizing, like fusing early when the patient's, just going to do this. You're not going to gain that much, and you'll get better correction when you go ahead and do it. And I think we have to let people know that fusion isn't necessarily a bad thing, when it lets them go back to the life they have and, not spending, coming in for, lengthenings every so often. So I think, fusion's got a bad name because people were doing fusions for back pain, not because of the fusions we were doing for scoliosis. And so we need to that's not really an answer to your question, but again, we have really good techniques, and we try to avoid too many levels. So maybe that's something that we can come to a happy medium rather than just avoiding fusion. So thanks.
What?